Also, before we started, just wanted to thank you, John, for your continued commitment to educating what I can see is a great range of people in the industry. Quite a few doctors on board today, quite a few plaintiff and a few defendant lawyers and case managers out there. So welcome everybody. Thank you for joining us today for Dr. Crock's seminar on carpal tunnel syndrome. I really value and respect the time that you make available to educating everybody in the industry. So thank you for your time again today. John, do you prefer to take questions through the seminar or at the end? How would you like to manage that?
If anybody's got a question in the middle, you can, but my feeling is people will probably just be interested to watch and then we'll just kind of ask questions at the end. But I do not mind being interrupted. That's fine by me.
Okay.
Yeah.
All right.
So we're good to start sharing the screen.
Yeah, over to you. And just letting you know that at the end, Lachlan White from Insurance Compensation Services will do a short little presentation on some of the data analytics and AI that he and his team have been working on, which I hope you'll find, well, won't be as interesting. Sorry, Lockie, won't be as interesting as John, but hopefully one day it'll be important to people as well. So thank you in advance, Lockie, as well. And John, over to you.
Okay. Well, thanks, Mark, and thanks Medico Legal Assessment Group for this opportunity to talk, which is kind of exciting. And it's interesting because I was called to give an expert witness in court a while ago. And that's sort of like doing a fellowship exam again. And so I actually spoke to the chief examiner of the College of Surgeons before I went into court. And I also spoke to a professor of neurology just to kind of bounce some ideas backwards and forwards, because when you're treating something day in and day out, that doesn't necessarily mean that you're answering questions in a courtroom explaining yourself. You know, you're just doing the job and that people get better or not. And, you know, so when you have to explain it to lay people, it was really interesting. So as far as the college is concerned, this is an idiopathic condition, which means we don't know what causes it, which is, that's why this is a fantastic opportunity to just flesh it out a little bit with you guys. In this sort of setting, which I'm really looking forward to. So can everyone see that screen now?
Yes, we can see that, John.
Yeah, all good. But got to say, the sound is not great, John. So I'm not sure what's happening in the internet.
I've got no feedback here. Can everyone see my screen? Is that okay?
Yeah, that's great. Thanks, John.
Middle of a massive storm. So I do apologise if the sound goes in and out. So this is a cross section of the carpal tunnel, and you can see here that the green bit that's just come on your screen is the flexor retinaculum, that is here where the pointer is. That's the median nerve underneath, and you'll notice above it is another little canal that's called Guillon's space. It was actually defined by a French anatomist in the late 1800s, and Guillon's canal is actually proximal to the wrist. And that little bit there that is commonly called Guillon's canal is actually called Guillon's space in his original paper, which I managed to track down. So here's a dissection of the nerves and the flexor retinaculum here. Number one here is the flexor retinaculum. number 7 is the median nerve as it's breaking up. It's 18 on this side, 7 on that side. It breaks up into a number of nerves. And then here's this is the little finger over on this side. That's the thumb on that side. This is the ulnar nerve running on top of the flexor retinaculum, but in its own canal, the Guillain space. And Guillain described a canal back here proximal to the wrist as well. Okay, so there it is, kind of made easy. That's just exactly what it looks like in surgery. And I am joking because it doesn't look anything like that. It's not that easy to find. So conservative treatment, which is something that older surgeons talk about, younger surgeons don't, I've noticed, because I'm a trainee for some of this. I train the trainees, and a lot of them just think everything has to be operated on. But you can actually start with conservative therapy, which I usually do, with a steroid injection, making sure that you put it in a place that's not going to damage the nerve, which is quite possible to do. You can stick a needle into it and pump steroid into it and kill the nerve with your conservative therapy, which is, so this is something that needs to be done by someone who knows exactly what the anatomy is. And in fact, I'm going to digress here because there was a really interesting talk given in 2012 at a combined American and Australian Hand Society meeting in Hawaii. And somebody presented that carpal tunnel was caused by a chemical disturbance in the flexor retinaculum, and that the mast cells on the undersurface of the flexor retinaculum change their characteristics in people with carpal tunnel, and it irritates the median nerve. So I think what happens when you put steroid in is you actually reverse some of that chemical imbalance. And later on, you'll see when we do surgery, we just cut that out, which is what surgeons tend to do. So you take away the area where there's a chemical imbalance. But that's when you translate that into a workers' compensation setting, it's kind of tricky. So that we'll talk about that more later on. So here's the injection that I do. I usually put 1 mil, not 2, of steroid. And I usually just put it usually on the just either side of the median nerve. And I go really superficial so that I don't damage the nerve, because there's a few cases where people have injected, particularly local anesthetic, straight into the nerve, but steroid would be the same. And then you get you can damage or kill the nerve by putting in your chemical. So you've got to be really careful where you put it in. The surgical treatment basically revolves around releasing the flexor retinaculum plus or minus Guillain space. So that's, some people do that, some people don't, and there are some cases you don't need to do it and others you do. And interestingly, I've been referred a few cases where general surgeons have done this operation on big, thick hands, and they've cut right down onto the ulnar nerve, released that, but not actually released the median nerve. And they thought they'd done the operation, and then the patient was worse afterwards than they were before. And that's because the median nerve hadn't been released and it had been irritated by surgery. So you kind of, it's not as easy as the pictures make out when you do the release. I tend to do a skin crease incision away from the median nerve proper, at a place where I can get to both nerves. And it really varies on what skin crease someone's got. So theoretically, you're supposed to be in line with the ring finger, but basically I find a skin crease, follow it so that the end scar doesn't look so good. It doesn't look so bad, and then they tend to heal better. So here we are, this is surgery. You're looking straight down there. The thing here, whoops, sorry. Here is the ulnar nerve and artery that running through Guillain space. This is the flexor retinaculum there. There's the median nerve. So that's a kind of textbook one where they're both just sitting there looking at you, and you've got to sort of go through the fat, find all the appropriate layers, release them. And you may not have noticed, but there's a palmar branch that in fact, I'll show you on running just above the flexor retinaculum there, and generally on the radial side of the median nerve, and that supplies the sensation to the palm there. That's at risk during surgery, and that's why I tend to try to stick to the other side of the nerve so that the palmar branch is in here undamaged, and as I dissect over here, I'm not likely to damage it at all. So here's a nerve where you can see the thing is just red and angry and compressed. You know, that there's obviously a lot of peritendinous scarring around there. And underneath that, there's a lot of angry synovium as well. And here's, sorry, I don't know why I did that. Here's another one. This patient actually had rheumatoid arthritis. So you can actually see the nerve is just almost black with the contusion right where the flexor retinaculum is. And that one was so bad that I actually went on and did a whole formal release of the forearm and did a full synovectomy right up to the forearm, because that compression was just so bad. I needed to be a little bit more aggressive, which gives you a really good look of where the nerve is. And if you can see the skin is here, you can see how superficial the median nerve is. This is the hand end is up here and the forearm end is up there. The nerve is really close to the skin. So Peter Callan from Geelong, where Daryl hails from that side, he presented a case where he had some anesthetic complications where the anaesthetist injected local anesthetic with adrenaline straight into that nerve and killed it on a few occasions, which was a bit distressing. Now, this is a median artery. So normally there's a radial artery and an ulnar artery go down and supply the hand, but in 1% of people you get an artery that's massive that runs underneath the flexor retinaculum, and that can be associated with the median nerve. Now, whether like people have that and that doesn't cause carpal tunnel, but it's just something that you find occasionally when you're doing carpal tunnel, and it's something that can get damaged during surgery. So you've got to be aware of it. Here's a case where there was a lipoma in the middle of the carpal tunnel. So that, again, doesn't cause the carpal tunnel, but it's an anatomical variant that you can, well, it's a pathological variant that you can find in the middle of surgery that can make surgery more complicated. And here's somebody that's got two median nerves running down through their carpal tunnel. And you can see the bottom one here has been really severely compressed through the canal. The other one, not so bad, but they had really severe symptoms. Now, all of those reasons to me are not a contraindication for doing endoscopic carpal tunnel release, which is a very sort of trendy surgical operation where you put an arthroscope down, or sort of a scope down the canal and then release the flexor retinaculum from the inside out. Those structures could complicate that surgery and make it more difficult, but they're not contraindications for it. But this is the motor branch that supplies the muscles that move your thumb. And that, I've got now probably 15 examples where I've seen that coming straight up through the middle of the carpal tunnel, through the flexor retinaculum, into the overlying muscles and supplying them. And this is called a Lanz 5 variation. So Lanz described 5 variations of where the motor branch takes off, and this is one of them. And the take-home message here is that if this was damaged during surgery, you wouldn't be able to tell afterwards other than the hand is weak. And surgeons are likely to attribute hand weakness to pillar pain or to other things and dismiss it and not recognize it. And so I think this is a wildly underreported complication of endoscopic carpal tunnel release, because in order to get the scope in, you have to create a space between the nerve and the flexor retinaculum. And when you do that, you would rip that nerve out. And theoretically, people say, if you feel resistance when you're creating that space, then you back out and you do it open. But everyone I know who's experienced has damaged nerves doing endoscopic carpal tunnel release, all at the start of their series, but they're usually the sensory branch to the middle finger, so they pick it up. They wouldn't necessarily notice that this nerve is gone. And one of my mentors, who's like the godfather of hand surgery in Melbourne, he did this towards the end of his career and said, I'm never doing that again. I had absolutely no idea that I'd cut that nerve until I saw the patient 6 weeks later. And that was talking about a sensory nerve, not this key motor branch, that at 6 weeks, the patient would just say, oh, my hand's a bit weak, but my symptoms have gone away, so I feel great. So off they go. And their hand remains weak because you've twanged their nerve. And to me, this is a wildly underreported situation with the endoscopic release. Here's another example, and you can see how that looks like the colored picture earlier on. Not, like it's really difficult to see that that's a nerve coming through the palmaris brevis muscle, through a layer of fascia over the thenar muscles into the muscles. If you're not looking for that, you could easily miss that and damage it. Here's another one, again, difficult to see. They're just flimsy little bits of tissue that can be so easily mistaken for a bit of fat or a bit of fascia. If you don't know to look for that, you can damage that. And as I say, I've seen this 15 times. You can see how easy that one would be to just pluck out with shoving a big scope down the middle of that. You just rip that thing out and you wouldn't even know. So that's my little endoscopic carpal tunnel release. It's very trendy in hand surgery circles to say that that's what you do, but I'd rather be safe than trendy. When I started training, people said that you needed to put a plaster on the hand for 2 weeks afterwards. I've never done that in 30 years. You can get the patients moving afterwards, and studies show that there's no difference between open and arthroscopic and endoscopic carpal tunnel release at 6 weeks after surgery. People who are advocates for the endoscopic say they get back to work quicker. Maybe they do, maybe they don't, I don't know. But I just put a light bandage on, get them moving again. And there's someone who's had it about a year later. You can hardly even see their scar because it's hidden in the skin crease line. So to say that scarring is a reason for doing endoscopic, in my mind, that's not a valid thing to say. So I tell people 2 weeks for light duty, 6 weeks for heavy manual labor. A lot of people are quicker than that. What can go wrong? And this is one of my favorite sayings is, what could possibly go wrong? There are so many things that can go wrong with surgery. And again, one of a senior mentor once said to me that there's no such thing as simple surgery, only simple surgeons. And carpal tunnel is not simple surgery, and it can really go wrong. Pillar pain is actually a side effect. It's not a complication. If managed appropriately with a good hand therapist, that'll get better after about 6 months. But when you do this operation, you're releasing the biggest ligament in the wrist, and so the dynamics of the wrist change, and other joints are going to be put under pressure, and that produces pillar pain. It's bad in some people, not so bad in others, but it's just a side effect of releasing the nerve. Wound infection can happen, and there are obviously people whose immunity is down or at risk, but it can just happen anyway. In my practice, wound infections are less than 1%, but they happen, and they can range from mild, moderate to severe. And if you get a bad one, then it doesn't matter what percentage it is, it's a terrible complication. Nerve damage is a very real potential complication. And as you can see, the nerves are not that easy to find. It's easy to get lost. I have done so many of these where I just think I would be hating to do this endoscopically, because the hands can be big and thick and the ligaments really strong. Some ladies, everything is just right there at your fingertips. It's super easy, and some people it's super difficult. And so nerve damage is definitely possible at any time, open or closed. But the main nerves that are recognized as being damaged with the arthroscopic is the sensory branches, typically to the middle finger. Scar problems can be huge. Nerve damage to the palmar branch, that's a really big deal, because if you produce a neuroma in the palm, then that can be a problem for a tradesman trying to pick up a hammer or something. So scar abnormalities can be a big problem, and that's why I tend to go to skin crease incisions. And in fact, I've got a feeling, Daryl, who's in the audience, I'm pretty sure that you described the mechanism of scarring and how when you made incisions along skin crease lines that the scars were a lot better. I think you were the first person to describe that. And that's absolutely been my experience in surgery. If you follow the natural skin crease lines, particularly in hand surgery, then the scars can end up being almost not noticeable. Now, regional pain syndrome, poorly understood, really complicated situation, and that can be absolutely disastrous. And I remember Bruce Connolly, a hero of mine, hand surgeon from Sydney, talked about a simple operation, in inverted commas, that he did on a friend of his who was an airline pilot, who never was able to work again because they developed regional pain regional pain syndrome after surgery, which they could have easily put off. So that's a devastating complication, and it's a lot more common than we think. It's a whole spectrum. So I tend to be very aggressive with referring these to a pain specialist early on if there's any suspicion that someone's developing regional pain syndrome. Flexor tendon weakness, I alluded to doing a synovectomy during the surgery because I think as part of this syndrome, often you'll see really angry synovium around the flexor tendons. And I don't know what's the cart and what's the horse, but it's just something that we observe. And so there's a percentage of people where this goes on to produce flexor tendon weakness after surgery. And again, sort of a grey area in our understanding. And then unexpected, and that's because anything can possibly go wrong with surgery that you just don't get. So I think that's the end of my talk.
Thank you very much, Dr. Crock. Are there any questions from the audience for today's presentation from Dr. Crock? And if there are any that come up later on, what I can do is I can pass them on and relay that information through to you, and we will be following up with some further information. Dr. Crock, again, on behalf of...
Lachlan, I was just wondering if I could ask Dr. Crock something. How long would you continue with steroid injections before you go on to surgery? My personal attitude is I'll look at the nerve conduction study and see how bad it is. Or, if people have terrible symptoms, despite, maybe not such a bad nerve conduction study. But how long do you do it? Because I used to do it a lot in the past. I used to do steroid injections a lot in the past, and they used to last for about 6 to 9 months. I've gone over to surgery because I've got a surgeon that's extremely good at this. But what's your opinion?
Yeah, that's a really good question, and I agree with you. It's very, very case dependent. This is essentially a clinical diagnosis. EMG study done more for workers' comp purposes to prove that you've got it. So it's interesting whether it's work-related or not. Look, it probably isn't. It's probably just a condition that some people are predisposed to for whatever reason. And so their work can aggravate it, but it doesn't cause it, in my opinion. So different people vary. So like some people have one injection and they're better and that's it, that's great. And that's why I do that in the first place. But more importantly, it's a really good prognosticator for surgery. So if you put a steroid injection in, someone gets better, then that will exclude a lot of proximal pathologies. So some people say the median nerve can get caught up around the elbow where it goes through the pronator teres. And some people routinely release the nerve up there. I don't, and I'm not super convinced that that's Look, it might be a thing. It might be the people that don't get better from carpal tunnel may have the compression up there, or they can have problems with their cervical spine. So if somebody responds really well to a steroid injection at the wrist, then I'm pretty confident that they're going to get better with surgery. So to me, it's almost like a prognosticator of where we're going. So I'll typically do it once. Occasionally, people will get a fantastic response for a year, and they will be really resistant to having surgery because they're like, there's a physician friend of mine who just couldn't afford to take time off work. So I gave him a steroid injection. He completely responded, and it lasted for a year. And then he said, can we just repeat it again? I did it a second time. It lasted a second year for a whole year. Did it a third time. It lasted a third time. And now it's come back and I'm saying, no, that's it. We just do surgery now. But he would get a year's relief at a time. And he was, without giving anything away, he was heavily involved at the coalface of COVID. So the last one was just before the COVID outbreak, and he didn't want to, he was so busy with coordinating stuff there, he couldn't take time off surgery, but now he's ready to go. So my approach would be very much on a patient by patient basis. And I use it as much as anything to make sure that the diagnosis is correct. And if they respond, then I'm happy to say, yeah, we'll do surgery. And in that way, if they get a complication, then at least you're confident that you did everything possible before you went ahead with surgery.
That's fantastic. Just a last question. It looked there as though you were actually injecting almost subcutaneously and not
That's
into
exactly. That's
so
exactly.
it seeps through the flexor retinaculum.
No, I'm way proximal to the flexor retinaculum. So it actually seeps through the deep fascia. Whether I actually even get through the deep fascia or not, I don't know. But if you massage it in, it seems to kind of do something and work, because, as I say, it can be like you've got skin, fat, investing fascia, then median nerve in that little window just before it goes, as it comes out from underneath the flexor digitorum superficialis muscle. It's adherent to that muscle underneath, and then it pops out just before it goes into the carpal tunnel. So, and that's where you can damage it. And I had a patient who'd come from interstate, and someone had put a needle right through the flexor retinaculum, and so right deep down around, I don't know what they were thinking, but they went right through the flexor retinaculum and then injected as they withdrew. And the patient said that they were literally crying with pain as the doctor was doing this, and they were worse afterwards and not better. And then I gave them an injection, just like I showed you, and they completely responded for 3 months, and then I went ahead with surgery. So, in fact, it was longer than 3 months. I think it was almost a year later they got a recurrence, came back for surgery. So it's a very effective technique, and it's just what works.
Thanks so much.
John, Derek in Tasmania.
Hello.
Can you hear me? Thanks. I would really back you up on the injections being a very good first interaction, because a lot of people do respond very, very positively. But I historically worked with a plastic surgeon in Melbourne, member of the Second-Hand Club, they call them, who always, you know who I'm talking about, but he always decompressed Guillaume's canal in all cases. And the decompression of Guillaume's canal seemed to be the difference for a lot of people between troubles afterwards and not trouble afterwards. Yeah,
that's really interesting you say that, because in fact, I just got an email today from a public hospital going, oh, why do you charge for 2 nerves when you're doing carpal tunnel? And that's because the DHHS is putting the screws on them. But that's been my experience as well. And just recently, the Hand Surgery Society have actually brought out a second MBS number specifically for releasing the ulnar nerve. So that's really interesting you say that, because that's my gut feeling too. But all these things are really difficult to prove.
Thank you.
Yeah, no, thanks I'm super grateful you made that comment.
Dr. Crock, we've got a couple of questions. Dr. Rajapaksa from Sydney has a question. I believe Dr. Nam has a question as well. So Dr. Rajapaksa, if you would ask your question.
Yeah, thank you. Thanks, Dr. Crock, for your presentation. I just wanted to talk about occupationally induced carpal tunnel syndrome, which the literature sort of reports with using vibratory tools and repetitive movements, or abattoirs working in cold industry. What are your thoughts on those? I guess from our medical legal sort of sphere, we get a lot of sort of reports. Is this work induced? Especially as you know, as you rightly said, it's idiopathic, and we don't know the cause, and it's pretty rare to affect young people. But that's the kind of, I think, things that a lot of medical legal work are involved with the young worker, repetitive movements, and then they develop carpal tunnel-like syndromes, and then we get the question, is this work related? I would be appreciated to hear what your thoughts.
That's such a good question, because people are really divided on that. And like some people say, it's never work related. It's just an idiopathic condition that gets worse. But then I agree. I've seen patients who have been perfectly okay, and then they're put into a specific situation, they develop it, and it gets really quite crippling. And so I'm not as so hard line as to say it's never caused by work, because I don't think that's really fair on some patients. But it's very much a clinical situation, and that's why, to me, the EMG is really just to verify to workers' comp that they've actually got the condition. And it doesn't even correlate to the clinical symptoms either. Like, I see some EMG studies that say it's severe and the symptoms aren't bad, and vice versa. So I wish I could give you a really clear-cut answer on that, because that's what lawyers want. They just want you to tell me, yes, this was caused by work, or no, it wasn't caused by work. And I would say, I think you have to be really good with your history. And if they had these symptoms prior to work, then I would say, no, it's not caused by work. They've just got carpal tunnel, but it's irritated by the fact that that they're doing a repetitive job, but that repetitive job hasn't caused their carpal tunnel. I think that's how I would word it in that situation. Daryl, could you make a comment on that, Daryl Nam?
I have lots of comments, but I'm not sure whether we have time for them. Thanks for acknowledging my incision, but I just wanted to correct you on the incisions in skin creases. Is the incisions in the skin fingerprint pattern? That is, the reti ridges, not necessarily the skin creases. So it's if you follow
yes, and that's exactly, every time I do that, I think of you. So yes, that was what I was meaning.
I, like you, have done a lot of carpal tunnel over the years, and I've been working in Geelong where there is I did a lot of people who are workers, and so we get a different cohort of patients. Some of them may not. You may get a lot that don't work. I get a lot that do work, and so I tend to be influenced by that. And I now do a lot of medico-legal work, and so my belief is that it is work-related, and my understanding of the pathology is different to yours, and I adopt a different approach to injection. I don't know whether you want to hear it, but I can.
Oh, no, I'd love to hear it.
Well, I started doing endoscopic uniportal carpal tunnel a long time ago, and I never did. I tried one or two of the dual port things, but I found that was too blind and too dangerous. So a uniportal carpal tunnel release gives you complete vision of what you divide. You don't divide anything you can't see. And what I'd like to say is that if you do ultrasound on the carpal tunnel and watch it dynamically, when you flex your fingers, you can see the median nerve get pushed over to the radial side, as the carpal tunnel starts filling up with the contents of the distal carpal tunnel, and that is the tendons and the lumbrical muscles. And they just get, when you flex your fingers, they get pulled into the carpal tunnel. When you do a endoscopic carpal tunnel uniportal, you have to put in a little dilator. And when you put that in, you feel that the carpal tunnel is the tightest distally. You get this very tight band distally when you do that. And that, I believe that when you flex the fingers, you pull in this tightened tissue into the carpal tunnel and you compress the nerve. So I believe it's a mechanical event, not an idiopathic event. When I inject the carpal tunnel, I inject into the carpal tunnel distally, where I believe this swelling is and where this distal block occurs. And so that's where I differ philosophically in this operation. And when you do the carpal tunnel release endoscopically, you don't go anywhere near the radial side. You stay always on the lateral ulnar side of the canal, so that the median nerve is less likely to be there. And you can even, if you want to do an injection, you can do it under endoscopic control. Ultrasound control. You can watch where the needle is and you can see where the median nerve is. And so you can inject quite safely into the canal if you want to, if that's what your belief is. And so I just wanted to make those points because they're completely opposite to what you're saying. And that's really my experience of it. And it can be quite a unique experience. I don't propose that this should be universal, but it's what I've experienced. How does that sit?
No, when I started training, and I don't know what you were like, Daryl, when you started, but when I started, I was kind of trying to please my bosses. And one of them said to me, if you lined up 10 plastic surgeons and asked them one question, you'd get 9 different answers.
That's right. Well, I'm apprehensive. I'm apprehensive about giving you a contrary view, but that's my experience.
No, I'm super grateful to hear it. And that's why I actually developed an algorithm that John Cleese put forward on a video training series for businesses. And he said, you develop the question, what are the alternatives? What are the risks and the complications? And then you weigh up the advantages versus the disadvantages. So for every case, that's what I go through. So I've given you my perspective, and I'm grateful that you've given your perspective. And with the skin thing, that's exactly what I had in mind when I was saying it, what you said, because I remember Wayne told me about it. And that's why I make my skin crease incisions in the palm, but I know you were talking about fingers and I do it there too. But yeah, with the endoscopic, I didn't start because of what the senior surgeons that I was working with experienced and the complications they had when I was an impressionable trainee, and I've had no reason to switch over. But you know, I mean, I'm not critical of what, I'm really grateful for what you said.
I switched over after one of my doctor's wives was a patient, and she complained bitterly to me about the pain in the scar. And I was like you, I wouldn't go anywhere near endoscopic carpal tunnel. But then I started exploring it, and I think I got proficient. I'm not saying that everyone was, you know, perfect, but that's how I got converted by a doctor's wife. The other comment I wanted to make is that when I was working in Geelong, we had a good neurologist who I tried to correlate nerve conduction studies with the severity of the symptoms. And more often than not, he was able to classify nerve conduction studies into mild, moderate, and severe. And so I tended to find there was a correlation there. And it was a bit of an indicator as to who I might pick out to be I inject with steroid. And most, like some of you listening, a lot of my patients were treated conservatively by injection. And I never did surgery, except when the injections failed. but a very, very large number did succeed. And I felt that putting it in the distal carpal tunnel in the canal was my secret of getting a good result.
Mm. Yeah, I was really interested when a young consultant recently at Monash, I asked him about conservative treatment. He never gave steroid injections. He'd just go straight for surgery every time. And I just think, you know, you can get burned. So I agree with you. I always try the conservative option first and then move to surgery if that doesn't work.
I tell patients that surgeons will operate on you if you go to them. That's the modern philosophy.
That's exactly correct.
Dr. Gilbert, you had a quick comment on causation, then we might move to a question from Professor Keogh as well.
Yeah, I think the problem with causation historically is that there's a real dearth of research in terms, and particularly in Australia, in terms of causation and carpal tunnel. So there have been practical outcomes. One of the landmark studies, if you like, really came from Europe and from Scandinavia with the meat industry. And so in Australia, the meat industry has pretty well accepted that if someone gets carpal tunnel in the meat industry, that they will be automatically accepted as a work-related injury. Other employers tend not to get the same treatment, but in a state such as Tasmania, when there are very long, I mean, extremely long waiting lists for people to have surgery in the public system, there's a tendency without prejudice by the insurers to actually fund the surgery at an early stage and get the problem over and done with, rather than wait inexorably until the person is in that more severe state, which they seem to inevitably become. So it's one of these conditions that tends to, once you've got it, you've got to get it fixed one way or another. Whether that's ameliorated by an injection or having definitive surgery. And my experience over time is that the earlier, the better.
It's really interesting you say that, because in fact, the case that I went to court for, I gave him a steroid injection and I said he was actually a meat worker from Wonthaggi in Gippsland. And I said it was work-related. I gave him a steroid injection and he responded. But then I had to get approval for the steroid injection, and then I applied for approval for surgery, and they delayed it for nearly 2 years. And then he got a very poor outcome. And I think you're right that if he had have just had the surgery, you know, failed steroid 3 months, just go straight for surgery, he probably would have been better. And Phil Slattery, who's one of the, you know, main carpal tunnelists in Melbourne, presented a really interesting paper on the long-term outcome of untreated carpal tunnel, which absolutely confirms what you just said, that it gets way worse if you leave it. And you look at those photos that I showed you, you know, you can imagine leaving that for a period of time, the nerves being hammered.
Yeah.
So,
and those outcomes are really poor. And the problem is it's non-clinicians making decisions on clinical treatment. And that is case managers and insurance companies who will always find someone to say you can delay it. But the reality is delay equals morbidity, I think, in carpal tunnel that is unnecessary. And so few carpal tunnels are just reversible on their own right. They're not likely to do that. So I think that this notion of encouraging employers to take some responsibility is actually a really good way to do it. And the insurers do come along for the ride, as I say, without prejudice, to fund something which is a hell of a lot cheaper then than dealing with a person who's not able to work.
Yes. Yeah. Super good point.
Just, if I can just ask then, John, Barry and Daryl, with regards to work-related carpal tunnel syndrome, are there, in your experience, are there any particular sort of jobs that you can clearly say that's a causation, or I guess you would have to do every case on an individual case-by-case basis, but as a general rule, or any pearls from the three of you with your experience with causation from a work occupationally induced carpal tunnel?
Daryl?
I have seen a lot of people in a medico-legal capacity claiming carpal tunnel where I don't believe that their work has caused it. And one would be people in the clerical industries who may be doing a lot of maybe some typing and filing. That I'm suspicious a bit about the cause of that. And it may be that it's an idiopathic late or middle-aged people who, you know, may have hormonal changes that are causing the swelling in their hands, because there are other causes in working which causes the swelling, and it occurs in pregnancy and some medical conditions. And so if I'm seeing a worker who has a physical job, and the meat industry is one of them, process workers working and packing on process lines, where I can correlate that type of repetitive hand work, where I believe that the small muscles of the hand are getting stressed and swelling occurs around them. That's where I can correlate and feel I'm confident that that's a genuine case.
Yeah, over the years, I've seen them much more within the meat industry, and certainly within that industry, it's the boners that are actually the problem people, not the slicers and not the packers. So boners presumably holding their knife and in such a manner that their flexion, extension and radial deviation as a repetitive thing to get the meat out. I think if you deny those, you're actually probably denying reality. Whereas a person who has a clerical job, and I agree with you, I can't think of any mechanical reason why they would have anything to do with keyboarding or filing.
You see, when you've got a hard grip, you're pulling all those lumbrical muscles, you're just putting extra tension in the carpal canal. When you physically see those muscles and things coming down with flexion, you can understand that there is some impingement on the nerve. And that's my belief in it. And it has been written about. I'm not the only one that's described this. It's been alluded to, but not enough research on it.
In fact, Daryl, I agree. So Daryl made a comment about there being a tight band distally. There's also one proximally, and they're both recognised causes of failed surgery if they haven't been released. So you have to actually find those, and it's almost like a piece of string that runs across at the far end of the canal, but also in the forearm just proximal to it where the deep fascia ends. And if they're not released, you can get problems. And so yes. I agree with you there. And I haven't heard your theory, and I'm super interested because that totally makes sense to me.
I think maybe some anatomic, it's hard to do it in non-living tissue because all the swelling's gone. But if you can look at it dynamically with ultrasound examinations, I think that'll be the answer to sort of resolving that and proving it.
So would you all agree that then that sort of clerical work is an unlikely cause, like the secretary that's been typing is an unlikely cause of carpal tunnel?
I think it's unlikely, yes.
Yeah, I'd agree with that.
Right. Where somebody who is, and where something much more physical, repetitive, like even lifting boxes and planks or whatever, there is a potential cause that because of the flexion extension, they could be.
I believe so. Yeah.
Right. Thank you.
Dr. Crock, we have a question from Professor Keogh, and the question is, do you routinely take samples of synovium for pathology? I'm a cardiologist and we have trouble diagnosing ATTR, apologise for my pronunciation, amyloid. There are reports of amyloid, AMYLOID in carpal tunnel tissue, and what is your experience?
There's times where I have done a lot of sent it off, but the problem is that incurs an extra cost to the patient. So recently I've stopped doing that, but so yes and no. But if there's any, like if anyone has got a concern, you can easily just send the tissue off to histology.
Great, thank you. And Dr. Kostos, is that a hand up from you as well?
Yes, it is. Thank you. I'm a rheumatologist. I've had a particular interest in carpal tunnel for many years. And it's interesting to hear everyone's beliefs, but in the end, you've got to come back to the studies. And we know there's well-established associations with middle-aged, perimenopausal women, obesity, diabetes. I'd see at least 1 or 2 workers' compensation cases every year that has rheumatoid arthritis that's never been diagnosed. There's been 3 to 4 excellent studies looking at clerical workers, shows no association. One study even showed less carpal tunnel in clerical workers. Whilst there are anatomical studies suggesting that there are changes in the ultrasound and findings such as contraction of the muscles, etc., you've got to look at the best longitudinal studies we have. And the 2 that are best are Nathan's study. He followed a variety of workers for, in the first instance, 5 years, but he's got some patients out to 12 years with annual nerve conduction studies. Now, these people undertook a variety of different jobs. Some of the criticisms of this study was that it was there was a dropout and some people changed jobs. However, the Nielsen study from Sweden looked at workers using handheld vibrating tools compared with workers who didn't, and followed them for 5 years with annual nerve conduction studies and found no difference in median nerve conductivity over those 5 years. So whilst there may be some anatomical variations, the studies do not support in the vast majority of cases that mechanical factors cause carpal tunnel syndrome. I agree that sometimes you just get a history of someone starting a new job and within a month they develop symptoms, and you have to consider that case in individual grounds. But in people who are working for years in the same job, the studies are clear that these mechanical factors do not apply.
Yeah, I agree with you that a lot of people are working in jobs and they don't get this condition, but you do see people that have suddenly changed their activity. And I think that they're the group that probably pop up with carpal tunnel.
Yeah, well, that's what I'm suggesting. Some change, but as I said, you've got to go back to the studies. You've got to look at the evidence, and part of the problem with the evidence is there's a lot of cross-sectional studies that do a snapshot in time of people and say, do you have pins and needles and numbness? And if they say yes, well, that must be carpal tunnel syndrome. A lot of these studies don't even do nerve conduction studies. There was one longitudinal study being spouted around town, but only a third of the people actually had nerve conduction studies. So, you've got to look at the evidence very carefully and, you base your opinion on the evidence.
I think that we can't say that it's all due to mechanical work, because you'd have a plague of people coming in with carpal tunnel. There must be some anatomical differences in these people that are suffering it that are, causing this condition. It's not just the work itself, it's them and their physical state. So that if you looked at the people that have got carpal tunnel, then you might find some differences between them and normal people.
Yes, some people work out it's the cross-sectional area of the carpal tunnel that may be a factor, which they purport explains why carpal tunnel is more common in women. But there are a number of other factors.
So, Tony, did you get across that study from about the mast cells?
No, I haven't seen the study on the mast cells, but obviously, if we're using steroid, we suspect an inflammatory response. I mean, I've injected a lot of carpal tunnels. I actually use a different technique. I was taught to use the bony landmarks, 0.5 ml just straight in. So I'm always on the side of the palmaris longus, and I've never had a problem. But I tend to reserve it for people who have mild to moderate carpal tunnel. There's also numerous studies showing that oral steroids can be as effective as injections. So there's some people who are shy of injections. So I find that I get a similar benefit from oral steroids. So, the effect of steroids is clearly on some sort of inflammatory process.
So, Tony, do you think we're at a stage, and John, that we're at a stage where we really should be, in the workers' compensation context, just simply drawing the line and saying that causation is in fact trying to attempt to define causation in the majority of people who present with carpal tunnel is not only going to be adverse for their clinical outcome, but a waste of time. Really what we want to do is to make sure the condition is treated in a timely manner.
Yes. Well, the only way you can get around it is if there's a history of an exacerbation of symptoms. So in Victoria, the definition of exacerbation is that you get a worsening of symptoms without any effect on the underlying condition, in contrast to the definitions of aggravation and acceleration. So if someone tells you that, yes, look, I have all these symptoms at work, but when I go on holidays, I'm much better, then you can say that there is a temporary exacerbation of their symptoms whilst at work, and that might hurry the process along. But as anyone who deals with insurance companies, you know that the claims agents have very little medical knowledge. They frequently change, and you know, files get left, you know, just left by the wayside at times. So it's a very difficult area.
So I guess we really should be advocating for our patients in that context for a better outcome. And the workers' compensation system is not doing them any favours whatsoever for a condition that is, what we're all saying here, is largely idiopathic.
No, the workers' compensation system doesn't do anyone any favours, because as soon as you enter the workers' compensation system, you're no longer a patient, you're a claimant. And that's the big difference.
Thanks all for that quite insightful discussion. Are there any other questions from anyone in the audience that I'd like to present to, I guess, any of the multiple specialists and specialties we have present today? Okay, and look, if there are any other questions moving forward, please feel free to shoot them through, and we can certainly take that from there. Look, before we all head off, I'll just do a brief screen share of some of the work that Insurance and Compensation Services is doing in terms of the data and analytics around what everyone's been going through in terms of assisting people in getting back to work, which is the key aspect of the workers' compensation system, is enabling everyone to assist the patients in returning to work in a timely fashion. I'll just share my screen very briefly. So Insurance and Compensation Services is a software and analytics firm that provides software solutions to the insurance and personal injury industry. We provided some class-leading workflow management system for all personal injury stakeholders, and some other products of ours include our telehealth solutions, our clients' sector-specific platforms, and some data and analytics tools. So one of the key services that we're working on at the moment is assisting or an AI tool for surgical quotes. So medical billing and invoice approval for surgery and compensation schemes is a critical issue for insurance agencies and specialists, and recent judgments by APRA have highlighted the need for more support to bill correctly in these, as everyone has outlined, these convoluted and complicated compensation schemes. And so we've developed a dual-use tool to assist our specialists to check their surgery quotes against the relevant compensation scheme, and to assist the insurers in quickly and accepting and verifying these invoices to enable them to approve them and improve the treatment quote validation for specialists and insurers to ensure that the patient can get into surgery faster. Another piece of work that we're working on at the moment is our machine learning for compensation trend analysis. So using our state-of-the-art data and analytics and machine learning teams, we assist law firms in their compensation decisions by providing access to a trend analysis of judgments across jurisdictions, which can assist them in their decisions with high quality and compliant data and analytics. We have some client-specific software tools, so for law firms, for government agencies, for insurance agencies, and for independent specialists. We provide a workflow management, booking and billing platform, which has been rolling out across Australia. And we have some other tools, including some open source data analysis projects to try and improve the knowledge and treatment decisions made in the industry, especially for insurance agencies, and some integrated telehealth solutions. Look, I won't take up any more of anyone's time. I would really like to thank, firstly, Dr. Crock for presenting today. It was an excellent discussion, and to also thank the other specialists present today, Dr. Gilbert, Dr. Nam, Dr. Jubert, Dr. Rajapaksa, and Professor Keogh and Dr. Kostos for their really insightful discussion. I know I'm very grateful personally for learning about it today, and I'm sure our audience is very grateful as well, and really appreciative of your collective efforts to improve the education industry. With that, we have hit 1:30, so I think everyone's lunchtime is up, and look, really grateful to have you all on here today, and hopefully see you at some of our future seminars. So thanks everyone very much.
Thanks for having us. See you later. Bye.
Bye-bye.